Hello, everyone. Thank you for joining us for today's webinar. We are very grateful to have Nora Cox joining us today, who is the Chief Executive Officer of the Texas eHealth Alliance. She is regarded as one of the most knowledgeable and effective healthcare advocates in Texas and beyond. She has spent 5 years in the Texas Capitol, helping shape healthcare policy, and is credited with leading major reform efforts in Medicaid, overseeing the creation of the state's Health Information Exchange, and playing a key role in reorganizing the state's fractured health and human services system. She is joining us today to talk a little bit about the impact of Medicaid cuts that were presented in the recent reconciliation bill that was signed into law, and to help us navigate the upcoming financing environment. Thank you so much for joining us, and I'll turn it over to you.
Lydia, thank you so much for that kind introduction. I hope everyone can hear me. I'm going to go ahead and get the slide deck up. I'm going to keep an eye on the chat. Hopefully everybody can see where we're going to get started. My goal for today is to tie these two things together. And if you were at the last CTEL in-person event in DC, we did have a panel and we talked about this, and Krista came back to me and said, can you get into a little more detail once the bill is finalized? And so that is what we are going to do here for the next little bit. Lydia, thank you for that kind introduction. For those of you that don't know me, I've been doing this a really long time. I started working on telehealth legislation in my state in 1995. When I worked for the previous governor of Texas, I actually negotiated a Medicaid supplemental payments waiver that did not get implemented because of the passage of the Affordable Care Act, but I have worked down in the weeds of this particular subcomponent of Medicaid financing. I'm a huge nerd. I started as a computer programmer, and then I founded the Texas eHealth Alliance in 2009 to do state level advocacy work in my state. And I love partnering with CTEL. It's one of my favorite things that I get to do. And I'm excited to be here today to sort of give you a feel of what actually is happening and what you can do about it. So we're going to start by decoding the dollars. What is in the bill? What did the final bill actually do in terms of Medicaid? Then we're going to talk about how this is going to shift things for various groups of stakeholders. And then finally, I think it's really appropriate to sort of say, okay, now you have a sense of what's happening. What are your action steps as an organization to prepare yourselves for the future, whatever it may look like? Whenever we do something like this, I think it's important to have learning objectives. And so really, we're going to start with an overview of Medicaid supplemental payment programs. What is the new financial rules going to look like? We're going to talk about the different stakeholder groups that could be impacted under new reimbursement structures, a little bit about winners and losers, although in some cases it may be too early to tell. And then finally, what kind of strategic response can you make as an organization, depending on where you sit, where you fit? Are you in one state? Are you national? What are your populations? I'm going to give you some guidance, hopefully that will be helpful. And then hopefully at the end, we'll also have a little bit of time for questions. So let's start with talking about the dollars, because that's the most important part. Medicaid supplemental payments are frequently referred to in a lot of different ways. In the nursing home industry, sometimes you hear them called a granny tax. You'll hear the term upper payment limit. You'll hear the term disproportionate share hospital payment. What is all of that? Let's start there, because this is the block of financing that has been focused on in this recent reconciliation package. So starting in the 1980s, CMS would permit states to obtain federal matching funds from taxes, either state taxes or in many cases, taxes on local governments. The taxes have to fit a certain set of rules. They have to be uniformly applicable. They have to be broad-based. This has been an issue. I'll just give you a specific example as to why those nuances are important. In Texas for a long time, we did not do a nursing home provider tax because we would have had to tax homes that had no Medicaid nursing home patients in them. They were veteran-only homes. So excluding them would have made the tax not broad-based, and political leadership in my state at the time did not want to tax veterans' homes and not be able to give them back any funding. So local tax money is used as match. And I'm going to primarily focus on hospitals because I think that's the area that is one most impacted and second most impacts CTEL stakeholders. Match dollars are put up, it has to be tax revenue. So again, in Texas, we have hospital districts. There are many different ways that states can arrange this. You put the match in, you draw down federal money, you redistribute it to providers. And the idea here is to close the gap between what Medicaid actually pays and the cost of doing business. And over time, the federal share and the overall share of provider tax revenue has grown. So in 2018, the GAO did an audit and they said, okay, it looks like it's about 17% of the state share of the cost of Medicaid is coming from provider taxes. That's a lot of money. And that was 2018, and I do think it's grown since then. So we're looking at a federal framework where they have said this is okay. It is okay to use these funds to match funds, draw them down, redistribute them. Again, they have to make sure that the programs are broad-based and uniform. However, this has become a real political hot potato. So as these have become more popular and Medicaid overall has grown, even in non-expansion states, there are policymakers who have become concerned that the program is growing in size. I've heard this referred to as money laundering, and I do take issue with that characterization. I don't think that's fair. But the allegation is the states are using these other pots of money, local tax revenue, whatever it is, to obtain matching funds instead of investing directly in the rates that they pay Medicaid providers. In other words, if the states were putting more money into the baseline rates and the rates were higher, then you wouldn't need these programs to close the gap between Medicaid and, say, either a Medicare rate or what we call an average commercial rate. So this got on the radar of Republican policymakers and think tanks. And so this became a really big deal in the reconciliation bill because these are payments that are outside of the direct service delivery setup. These are payments that are distributed, but they're not distributed based on a specific patient's care. There are formulas that are used to determine how much money goes up, how much money goes out, that sort of thing. The Republican policymakers definitely want to see states making more of an investment directly in the baseline program instead of using these financing mechanisms. I will tell you that that is difficult for states. Medicaid is more expensive than it used to be. It's consuming more state tax dollars than it used to. And being able to leverage these local tax dollars through these arrangements has helped keep hospitals viable, particularly rural hospitals and safety net hospitals. However, they were able to put a fairly significant cost savings on sliding these numbers down. And so what has happened is the bill imposes a moratorium on new or increased state provider taxes. It restricts existing taxes, particularly in states that have done Medicaid expansion. And this is going to deliberately limit states' ability to finance their Medicaid share through provider taxes. The CBO scored this at $191 billion over 10 years. It's a lot of money. And that should give you a sense of how much money has been passing through these taxes in the program to begin with. So they've put it on a timeline. And towards the end of the presentation, I'm going to talk more about timelines, but I want to make sure that everybody understands that this is going to be a phased-in approach to the provider taxes. So there is a 6% threshold that's called the whole harmless threshold, about how much you can do without having to jump through sort of additional federal hoops. That's going to start sliding down in the expansion states. And then there is a 0% threshold for new provider taxes. So cannot do a new provider tax under this legislation that has been passed. The cuts will phase in at 0.5% and then phase down to 3.5%. Non-expansion states, again, Texas is one of the non-expansion states. We can keep our existing provider taxes, but we cannot increase them. So what that means is as the Medicaid population continues to grow, as the margins get slimmer for providers, this is a mechanism that states would have traditionally looked to and said, okay, can we get local tax dollars? Can we identify pots of funds to put in to draw down more match that's not necessarily baseline state revenue, and use those dollars to supplement our Medicaid rates, because states have to balance their budgets. And that does create some downward pressure on Medicaid rates. It's part, not all, but part of the reason Medicaid rates are considered to be lower than Medicare or commercial rates, because states do have to balance their budgets within available revenues. The federal government, as we all know, does not have to do that. And the Biden administration put out some incentives for people to do some of these things programmatically and to do Medicaid expansion and to reach out to those populations. The bill philosophically reverses a great deal of that. And this is one of the places where it is reversed in a pretty significant way. So if you're a Medicaid expansion state, your amount of revenue that you'll be able to pull down through provider taxes is going to reduce. You will not be able to create new provider taxes. If you're a non-expansion state, you get to keep your existing provider taxes, but you're capped. You won't be able to increase them from wherever they are. This is a big deal. We are talking about billions and billions and billions of dollars that go into the Medicaid system through these supplemental payment programs. But I don't just want to talk about supplemental payment programs. I want to also talk about something called state-directed payments. So state-directed payments started a little over 10 years ago-ish, and CMS stepped in and decided that this was something that they needed to regulate. So across the country, about 75% of Medicaid recipients get their services through a contracted managed care organization. Texas is like 95% managed care. What that means is the state is not setting the rates directly for most of the providers under that MCO framework. The managed care plan is the one setting the rate, not the state directly. And it's supposed to, allow some flexibility region by region. It's supposed to give the MCOs incentives to negotiate with providers, that sort of thing. What it really does is give some budget certainty, because you're passing a chunk of money out of the state's coffers to the MCO and saying, okay, again, in Texas, we have what called rate corridors. Health plans can only make so much money, and then they have to return the balance to the state. So it gets really complicated. What you need to know about SDPs right now is that they allow a pass-through through the health plan directly to the provider. So if I'm a state Medicaid program and I am primarily managed care, I don't do rate setting. The MCOs do rate setting, and they can charge different rates even inside the same service area. A state-directed program says, oh, wait a second. I'm going to pick an example. We're really concerned about maternal mortality in South Texas. So we're going to take a chunk of state money. We're going to give it to the MCO and tell them they have to pay that rate through to those providers. So it's the state getting a little more involved in rate setting in managed care, which is not ordinary. But it has to be done for a purpose, either increasing access, increasing quality, frankly, or both. And an SDP still gets federal match. So the amount you can pay is capped. You don't have an unlimited federal match. Some use Medicare, and then many of them actually use the average commercial rate in that area as the target rate for the funding. So in the maternal mortality example, you might then get actuarial data that says, for prenatal visits, we normally pay this much per visit for Medicaid, but for the average commercial rate is 25% higher. We're going to set aside a chunk of money. We're going to pass it through the health plan to the providers directly to increase their payment rate to the average commercial rate for that area. So this is a little bit heavier state hand in rate setting in managed care. This does have to be approved by CMS. You can't just do this because, again, this is federal matching funds, so they are at the table. If you are a state that is fee-for-service, or if you are serving a program that is fee-for-service, you can do rate increases in fee-for-service directly. You don't have to do a state-directed payment. You can just say, hey, we're going to do a rate increase for this population. The legislature can appropriate the money, and it can be passed through a rate. But if you are a managed care state, which I'm going to talk about some numbers at the end, most of us are. There's some flavor of managed care almost everywhere. A lot of states have taken advantage of this tool to pass dollars through. Well, messing with supplemental payments was not enough. So these state-directed payment programs have also been altered by the passage of the recent bill. And it does a couple of things. The first thing that it does is it caps the amount of payments that can go through that insurer to the providers to no more than 100% of Medicare rates for Medicaid expansion states and 110% of Medicare rates for states that did not expand. What that means is if you're participating in a state-directed payment program that uses the average commercial rate for the payment rate, that rate is going to go away. And depending on whether you are a Medicaid expansion state or not a Medicaid expansion state, you are going to be getting less money for providing those services. So I am not here to argue the wisdom necessarily of taking away average commercial rate. I know that Krista, when all of this first started, actually got some calls from people that were very concerned that they were participating in these sorts of programs and that average commercial rate was going to go away. Philosophically, the Republicans in Congress feel like that's sort of a money-making rate and that they don't want people making money off of Medicaid patients. I would argue you should at least be covering their costs. So if you want to say average commercial rate is too high, 110% of Medicare in some cases is probably going to be enough. In some cases, it won't be, plain and simple. The other thing that it does is it phases down existing SDPs by 10 points per year until they hit the cap as proposed in the bill. Now, you may be thinking, oh, I've never even heard of this. Your state may not have one of these. Why is this a big deal? This CBO score for this component of the bill was $149 billion over 10 years. So there's a lot of federal money that was being pushed through these state-directed payment programs. When they tallied it up, they realized that this was an area where they felt they could propose a reduction that would not directly affect services to the most vulnerable populations at the baseline of pregnant women, children, age blind and disabled. The folks that put this in the bill believe that they are preserving and protecting those populations and that some of these programs, supplemental payments, state-directed payments, are the states, and I'm using air quotes, hope everybody can see me, air quotes, gaming the system to get more money instead of putting the state's own revenue into increasing Medicaid rates. But as I stated previously, it is just not that simple for states to just magically create an additional pot of revenue to fund their Medicaid programs, especially with the growth in Medicaid over the last 10 years. It's a really difficult proposition. So this starts in 2028. And again, this is this phase down of the existing SDPs, and then there's not going to be necessarily more of these, at least not at the average commercial rate. So if you're participating in something in pediatrics, in maternal care, those are two commonly used examples, you could see the rate you're being paid for services drop a little bit if you were being paid through an SDP. So these are the two very specific changes that in discussions with Krista, I wanted to talk about today. However, before I start to talk about impact and strategy, I want to make sure I highlight some of the other Medicaid changes in the bill, because these are also going to create some churn that I'm going to talk about that is going to impact everybody that serves Medicaid populations. I'm sure everyone in this call probably knows that the work requirements for the expansion population to maintain eligibility were a big deal for the Republicans that worked on this bill. This also tightens up eligibility redetermination. So instead of annually, now it has to be done 6 months. And there's some increased administrative requirements for verifying information about patients. Certain expansion populations will now have required cost sharing. So again, when I talk about Medicaid expansion, the folks that put this together see the expansion population as above and beyond that baseline population of pregnant women, children, age blind, and disabled. So they felt, I think, comfortable putting these requirements in. This next one is a really, really big one. I want to make sure I flag it because I think this is important. Traditionally, Medicaid has done a 3-month retroactive coverage payment policy because it takes some time to get somebody enrolled in Medicaid. They are now capping retroactive coverage for expansion enrollees to 1 month instead of 3, and then 2 months for traditional Medicaid beneficiaries instead of 3 months. So that may mean that a new person comes into the system, the hospital, perhaps the social worker figures out they qualify for Medicaid. That is not an overnight process, as everybody knows, but the hospital is perhaps supplying services anyway because the patient is in need. You used to be able to rely on a 3-month look back capture retroactively to get some claims paid. Now in this case, they've tightened that up a little bit. There was also a temporary FMAP bump to try to get the states that hadn't done Medicaid extension to come across the line. And that is eliminated on January 1st. I believe North Carolina took advantage of this. I'm not sure any other states did. So that expansion incentive goes away. And then some restrictions on coverage for non-citizens, which in some states is going to cause some real political heartburn between those states and the administration as this moves forward. So you're going to see this is one of those two things can be true at the same time. And I'm not choosing a side. I'm trying to be descriptive and fair and even-handed, even though I have, you can probably tell, very strong opinions about this. The Republicans who put this together believe that this is returning the program, like I said, to an emphasis on the baseline. Who are the oldest, sickest, poorest, most in need? Cover pregnant children, cover women, cover age blind and disabled. I suspect had they had the opportunity, they would have gone after the Medicaid expansion even harder than they did. And at some point that does become a tough political sell because that's been passed in red states and in some cases by public referendum, not just by legislative action. So I think they picked their battles to figure out where they could find the cost savings they were looking for, because of course the whole point of this was to create enough cost savings to fund extension of the tax cuts. So this is deeply politically charged, it's deeply politically sensitive. It is true that nothing I just described impacts those baseline programs and populations in a way that is really kind of one-to-one direct. But I'm also not going to tell you that everything I just talked about doesn't impact your state's Medicaid population in general and doesn't impact your state's Medicaid provider population in general, and isn't going to potentially impact how telehealth plays out in your state, depending on how your state is arranged from a payer mix perspective. And I'm going to talk about that some more here towards the end. So these are the changes. They're kind of a big deal. I'm going to go over the timeline before we're done too. So keep in mind, hospitals are primarily impacted by those supplemental payment program changes. The state-directed payment programs are going to be for specific populations and specific needs. There may or may not be one that impacts you. And then all of this sort of churn around tightening up eligibility, tightening up verification, putting work requirements on the expansion populations, reducing retroactive coverage. All of this is going to create real pain points in some place just a general feeling of chaos. Some of it may be noise, but I don't think as a community, the telehealth community can pretend that this is not happening, because this is definitely happening, and it's definitely going to have some pretty significant impact on healthcare in every state in the country. So now that we know what's happening, what is this going to do to different stakeholder groups? I broke this down sort of into three groups, and I want to start with the shifts for providers. I think there is general consensus that rural hospitals, children's hospitals, safety net hospitals, community-based providers are going to be the most vulnerable under these new provisions. And the main reason for that is because the programs that are being cut are the ones that are used to close the gap that I mentioned previously, the gap between Medicaid cost and actual cost. So I don't know of any other industry where people are required to accept a payment rate that is below their cost, but that is what we have done in Medicaid writ large across the country. And that's the reason for the growth in these supplemental and directed payment programs to close that gap. Now, to try to soothe some of the angst over what this is going to do to hospitals, the bill does establish a $50 million 5-year rural health transformation program for rural hospitals that CMS will administer. I think it is health tech friendly. I think it may even be telehealth friendly, although I haven't seen the word telehealth specifically tied to it yet. I know there's discussion of putting even more money into such a fund. So there's still going to be some questions about how to apply, how long is that going to take, what does that money look like, what are the accountability outcome measures for that money. But I don't think anybody is pretending that they don't know that this is going to put rural hospitals at risk. So a lot of the work that we do in telehealth is focused around these populations that, a community that can't afford to have a full-time nephrologist might be able to bring one in via telehealth. Mental health care for a lot of communities is also frequently done remotely because they just don't have physical providers that they can get to. So it is these safety net hospitals, rural hospitals that folks are concerned about. We've had a closure recently in Texas that people are pretty upset about. Our legislature just did a whole rural hospital rescue package, which was pretty great. This is an area to keep an eye on. So if this is the area that you work in, that churn that I was describing, the reduction in those two payment programs and then the overall churn from the Medicaid changes in the bill probably going to hit you like a wave, and you're going to have to find your footing in a slightly altered environment. I also wanted to talk for a minute about telemedicine and telehealth platforms. None of this is aimed at telehealth, pro or con. We really are not part of the conversation, although I would certainly argue that we could have been and should have been. I will say this, the top line thing that may happen to you if you're a telehealth provider and you primarily serve Medicaid is you may have to accept lower rates for services. That just may be the new reality. That churn I was describing may also mean that if you're in a per member per month arrangement, they might come to you and ask to take that fee down a little bit as revenues start to tighten up. We also, from a sales perspective, may for a while see that providers are less willing to take on large upfront costs because they just don't have the cash. I am an advocate for value-based purchasing. I think that's probably not just because the state-directed payment programs go away doesn't mean you won't be able to enter into value-based purchasing arrangements with health plans. I think that's very much still going to be a thing. The bill does not touch value-based purchasing arrangements with health plans. That state-directed payment programs are targeted rate pass-throughs. It does not change value-based purchasing. Now, if your SDP had a value-based component, again, your state may be working with a smaller pot of money, and you may have to come to the table to have that conversation, but it doesn't take away the ability to do value-based purchasing through Medicaid, either with the state or with the MCOs. And then finally, for patients, again, I'm trying to be fair and even-handed here. I think the folks that put this together really believe that this brings Medicaid back to a focus on those that are most in need and the original baseline program, which, I mean, frankly, is throwing shade at the Affordable Care Act. I'm not going to pretend that that's not real. Even so, the rate changes, the work requirements, the administrative requirements, people moving off and on, is going to have a couple of impacts. It's not just going to impact safety net providers, but it's going to have an ancillary effect on patients and their willingness to seek care. So if they are churning off and on Medicaid, maybe they're a seasonal worker, so sometimes their income's too high, then they qualify and they sort of go back and forth. When they're in the gap and they don't have coverage, if they haven't picked up like a marketplace plan or another sort of insurance product to cover them when they make too much for Medicaid, they will delay seeking care. We know this to be true. So I think that's an important thing to acknowledge, that even though I don't think anyone who worked on this bill intends to create a situation where patients delay seeking care, we know that when patients move on and off products, Medicaid to private insurance to uninsured, they move around, they also delay seeking care when they don't feel like they've got the coverage that's in place that they need. So I do expect to see some impact on patients from that as these changes get implemented. I'm also a little bit concerned, and I didn't put this on the slide, but I think it's fair if I articulate it. People are very confused about what the bill does. There's been a lot of press about hundreds of billions of dollars in Medicaid cuts. And if you don't read the whole article and you don't know what these programs are, or you're on the other side and you understand very much what these programs are and how it could potentially reduce services to patients, that is concerning. And that's an important thing to keep in mind as we sort of shift into the pivot. So we're going to spend a few minutes here on the pivot, and then I want to open up for questions. I did see one question in the chat, and I want to go ahead and address it from Rose. The question is there any sense if the home will remain an eligible originating site for Medicare patients with these implications? This piece of legislation does not speak to that at all. The focus here was really on Medicaid and particularly on hospitals. So I am not aware of any conversation about taking away the home as an eligible site for Medicare. The CTEL staff may know things that I don't, but Medicaid is my thing, and I have not heard any discussion, and it's not in scope for this bill, which is maybe the most important thing that I can say in terms of that question right now. So Rose, I hope that was helpful. You can always connect to me through CTEL later if you want to talk about this more. So Plan for the pivot. What does that mean? Well, first of all, payer mix is different from state to state. So if you're a telehealth provider, even if you're a 50-state telehealth provider, you may know what your payer mix is writ large. You may even know your payer mix from state to state, but I know from having conversations with folks over the years that not everybody knows exactly what kind of payer mix is happening in each state. And in this case, we might see some shifting of populations. So I always recommend, and I recommended before this bill passed, and I'm going to recommend till the end of time, that it is really critical if you're doing this, whether it's in one state or many states, to understand your state's enrollment distributions. And what I mean by that is you've got your large multi-state plans that serve, American Airlines or Home Depot. Those are those ERISA plans regulated out of the Department of Labor. You'll have your Medicaid program at the state level. You've got your Medicare fee-for-service program at the state level. Should have given it its own bullet. In many states, you have what we call dual eligibles, people who are Medicare and Medicaid. They may be in a special kind of plan, or you might have state regulated insurance. And again, because I'm in Texas, I'm using my own state as a reference point. Our state Department of Insurance only regulates about 17% of the market. So if we want to make a big policy change, it's good to make it at the Texas Department of Insurance because it captures those plans, but it does not capture those ERISA plans, which tend to make up the majority of the private insurance plan in any given state. So understanding, first of all, where your state sits, how big is your Medicaid population, and then the programs and people that you're serving is going to be important. If you're in a program that by design primarily serves Medicaid, you might want to think about diversifying into new markets. And I really struggled about whether or not I was going to actually put that in writing. And I decided I think it is important to understand that particularly in the expansion states, some of these changes are going to cause program enrollment. So if you rolled out a Medicaid offering targeted at the expansion population using telehealth, and I'm not saying anybody on this call did or didn't do that, I'm using it as an example, by design, there's going to be churn. By design, there may be fewer people accessing that benefit. So it's really important to take a look at where your state sits vis-a-vis everything I just talked about. The impact is going to be different from state to state based on their policy choices. So for example, 41 states have expanded Medicaid, but that means there's a handful of states, including my very large state, who has not. So some of these targeted cuts that are kind of pointed at the expansion population, and work requirements is a great example. No matter how that's played out on the ground in the states that have already tried it, the Republicans in Congress thought it was important for able-bodied people receiving this benefit to at least work or volunteer. Again, I'm not saying I agree or disagree with their policy choice, but they have made a policy choice that isn't going to impact the Texas Medicaid program the way it's going to impact the Medicaid program in expansion states. So you probably know if your state's an expansion state. Information is fairly easily available online. That's going to be important for you to know. And then in your state, are there supplemental payment programs, and are there state-directed payment programs? So every state has some form of supplemental payment. I think almost every state has it for hospitals. Most states have some sort of SDCs, but again, they vary per state. The rural providers are the ones that are considered to be most at risk. And what we don't know, one of the great unknowns of the way this package was put together, is whether that $50 billion rescue package is going to have enough to cover the losses of the rural hospitals if, let's say, worst case scenario, you're an expansion state and your expansion population drops, and then you have a supplemental payment program for hospitals, and then all of a sudden you're also receiving less money for that. And maybe you were participating in a state-directed payment program to boost maternal mortality in your rural region, and all of a sudden that has dropped from an average commercial rate to a Medicare rate. All of that is a squeeze day off. And so I do think that it is an open question as to whether that $50 billion is going to be enough, or if we're just creating another funding mechanism to make up for the fact that we underfund Medicaid rates across the board. I'm a little concerned that we're going to come all the way through this process and look at that rural hospital fund and say, yes, it was absolutely necessary. However, we've just recreated the supplemental funding program. We've just done it only for rural hospitals and under some very specific circumstances. $50 billion is obviously less money than these two provisions combined are targeted to save across the board. And then you add the work requirements, that's going to save potentially, based on the CBO score, and billions and billions of dollars projected. So states may have to step up. States may have to reconfigure. States may have to get creative, and everybody's tired. COVID wore everybody out. I think everybody's still a little bit feeling some COVID fatigue, but it's going to be important to look at the payer mix, whether you're in one state or you're across states, and understand, okay, my state has billions and billions of dollars of supplemental payment money flowing to hospitals, and now there may be less. And the programs that I serve at those hospitals, I'm going to need to pay maybe closer attention to those programs, make sure I'm delivering value and that I'm not caught off guard by changes that those systems might make. So that's the first part of the pivot. And this is really important no matter what Congress is doing. It doesn't really matter. You have to understand payer mix. And one of the most frequently asked questions that I get across the board, and I got this call 2 weeks ago, a stakeholder called me and said, we can't get, I'm going to make up a name, Frank's health plan to pay for telehealth. And I said, well, is that ERISA plan? Is that Texas Department of Insurance regulated Frank's health plan? Is that their Medicare product? Is that their Medicaid product? The person I was talking to said she didn't know. So just like with place of service for coverage or all these other things, you've got all these flavors in your payer mix, and Medicaid moving things around sometimes has a ripple effect. So it's really important to have a grip on where those dollars are coming from and whether or not your contractual relationships are within the bounds, kind of the Venn diagram of expansion, supplemental payments, state-directed payments, that sweet spot in there. Had I thought of it, I would have put the graphic in the PowerPoint. Maybe next time. It's important to understand how all those things play together. So in terms of planning for the pivot, that's the first thing. The second thing is the timeline, and this is about to get political, so brace yourselves, everybody. The Republican congressional leadership made some very deliberate choices in terms of the implementation timeline for these benefits. Almost none of it kicks in until after the midterms in November of 2026. So, for example, the work requirement for Medicaid is supposed to take effect at the end of 2026, but it gives the HHS secretary some flexibility to push that date out. The pre-enrollment verification for the ACA is not Medicaid, but it's the same sort of thing. It doesn't even kick in until January 2028. You can see limiting immigrant eligibility for subsidies. 2026, 2027, that's still going to be potentially past the midterms in November. So CNN did this chart, and it was too small on one slide, so I split it. Increased eligibility checks for Medicaid kicks in December 31st, 2026. Changes to the provider tax rules start phasing in 2028. So there's an argument, and it's a fair one, to be made that says the reason you want to do the phase in this way is to prevent a shock to the system, give everybody time to make adjustments, talk to their legislative leadership, decide what they want to do. But I'm not going to sit here and pretend that anything that's starting after the 2026 midterms or the 2028 general election, there might not have been some calculated thought behind that as well. It's the same thing with the requirements for cost sharing. So I put the URL for the chart on the slide. CNN did a great job sort of showing some of the strategy, right, that was put into this. And I think this is one of those things that I like to call Nora's first law of public policy, which is more than one thing can be true at the same time. I think they are pushing off some political pain, but I also think these are the sorts of things that are big and messy and complicated, and state legislators have to be involved and governor's offices have to be involved, and it takes time. Take it from someone who's done the work. You cannot just pivot and make these sort of shifts overnight, not without potentially significantly really damaging and impacting your payer base. So, final slide in terms of strategy. Here is my advice for what that's worth. If you're concerned about all this, and I'm guessing you are if you're on this webinar, now you know the timeline. So the first thing is the telehealth community needs to be linking arms with the broader advocacy community. And I think CTEL does a great job with that. We had some discussion about that at the last meeting in DC. If you're not already working with your hospital association directly, you should be doing that. They are at war. But every hospital in-house government affairs person that I know, plus my hospital association in Texas, plus my rural hospitals have all been in DC, all working on this. You know, the rurals are the ones that everybody's the most worried about, but don't just do that. That's good, but perhaps not enough. You might have a children's hospital association you can partner with. Link arms with those providers that are going to be impacted. Every member of Congress, except for a handful, has a hospital in their district, and if they don't have a hospital in their district, they're probably even more sensitive to these dynamics than the ones that do. So step one, link arms with other groups. Also look for patient advocacy associations. I know I'm hearing some conversation from the rare disease community, folks that are worried about, you know, making sure that the children's services are still covered and children's providers are not disproportionately impacted. That's not the intent, but like some of those state-directed programs might get up into that space. So patient advocacy groups are always important. And then, you know, never ever underestimate the power of higher education. Those institutions who do not necessarily technically lobby, they educate, have an awful lot of influence, particularly with the Congress critters in their districts, or maybe the governor's office. So lift up your head, look outside your telemedicine space and look for those partnerships, and then go say, hey, what can we do? How can we help? There's a multiplier effect, especially if you can coordinate on talking points. And the reason that I say that this is important is because you don't want to end up in a position where group A is saying this is going to be the impact and group B is saying this is going to be the impact. At some point, that sort of becomes white noise. So the more coordinated when it comes to your delegation that you can be, the stronger your advocacy message is going to be, because then the staff person or the member isn't like, well, I mean, is it the rural hospitals or the children's hospitals? Like, explain a little better what's going on. Anecdotes are powerful. Data is even more powerful. The risk of rural hospital closure in my state has been quantified and explained, and John Henderson, who runs our Rural Hospital Association, has done a really good job communicating very clearly to policymakers in my state and in DC what is going to happen if we don't support our rural hospitals. It's also important on that coordination to be in agreement about the solution. And so I'm going to pivot to something that I just learned this morning. So I wrote this deck, you know, over the past week. When I say was your House member or senator on the bubble, what I mean is, were they one of the last ones to get on board to vote for the bill? That stuff is pretty highly publicly documented. If that's the case, make contact, make sure you explain how these cuts are going to impact patients and providers. These issues will, in the slide I said, will be revisited after the midterm elections. As of today, I'm revising that. I think they're going to be addressed a lot sooner. I understand that Senator Josh Hawley, who was concerned about these cuts the whole time, has already filed legislation to repeal the changes to hospital supplemental payment programs and the changes to Medicaid state-directed payment programs. Now, that legislation is going to have a cost, and it's going to be close to $300 billion over 10 years to restore what was removed by those two changes. But he voted for the bill. And so that's, to me, symbolic of a number of things, including, you know, this is how tight the margins are for the speaker, for the Senate Majority Leader. We've had a number of resignations in Congress. The numbers are just so, I've never seen it so tight. So if these cuts turn out to be deeply unpopular, it may not be the midterms. It may be that Congress is forced to take some sort of action. The other thing I've heard floated around a little bit is doubling down on the Rural Hospital Rescue Fund. So maybe 100 billion instead of 50 billion cash infusion out to those hospitals to make sure that they're not damaged by the changes. So members like Holly who are on the bubble need to hear, and I'm sure he is hearing, because he was sort of cranky about all of this while the bill was being put together. Figure out who those people are, give them facts, give them data, talk to them, be a consistent drumbeat in their ear, bond with, spend time with their staff. Staff are critical, because this is not over, y'all. This is not over by a long shot. Yes, the bill was passed. The president signed it. Everybody was happy. This fight over these Medicaid changes is not over. I do expect it to continue. And so I think it's incumbent on all of us to do our homework, understand how this impacts our businesses, the patients we serve, the providers that we are, the providers that we work with, and take advocacy action as necessary. So with that, I wanted to leave a few minutes on the clock for questions. And of course, if there aren't questions, we can give everybody time back. I'll have the CTEL folks share out the webinar and the slides. You can reach out to me if you have questions about anything that I talked about. And with that, I'm happy to look for raised hands or take questions in the chat of this or anything that's related that you want to ask me while you've got me. Clear as mud, right? This is highly, highly complicated stuff. The other relationship I would recommend that you build, if you don't already have it, would be with your state Medicaid director and the folks that are going to be over the implementation of this stuff in your state. That's a really important position, because that's sort of the fulcrum between the political stuff and the implementation stuff. We actually have a National Association of State Medicaid Directors. Those folks all work together. They all know each other. I worked for the Texas Medicaid Director years ago. If you don't already have a friendship with your state's Medicaid director as a telehealth advocate, go establish one. Because to the extent that you can bring data to the table to talk about how the work that you do is going to be negatively impacted by this stuff, that is very helpful, because I'm sure all of them are looking at their programs and looking at this and trying to figure out, I'm caught between these big titanic political forces. Like, how do I make all of it work to protect the folks in my state? So Medicaid directors, governor's offices, congressional delegations, state legislature, this is why advocacy really matters. And this is why the advocacy that CTEL sets up really matters. Because Krista and her team's ability to talk to people on the Hill, the congressional staffers working on this stuff, the folks at HHS that are going to be working on it, is really, really important. And quite frankly, this whole thing happened because someone called Krista with a question, I think, about average commercial rates. And she called me. And then the next thing we know, we had a panel. And then the next thing we know, we had a webinar. And now hopefully all of you have a little bit more hard fact information and some strategy. So you're not starting from scratch, and you can customize whatever it is you're going to do for your state or the multiple states that you might serve. Oh, Carol, yeah, call to action, y'all. I mean, here's the thing. People are very upset about this. I get it. Being upset is not enough. You got to channel that into action. You've got to do specific things. You've got to make sure you understand that playing field. You've got to make sure you do your advocacy. You've got to make sure you talk to people like Krista and Lydia that are on the front line working on this. We are a powerful force as a community, and I've seen this community do great things. So go link arms with like-minded people in your states, and I think you can really, I think we can all really accomplish some really great things here together. Rescinding the cuts is already on the table. I think it's unlikely given the numbers, but we lose enough rural hospitals. I think Congress won't have a choice but to act, and hopefully they act sooner rather than later, and maybe we can head some of that off. Last call for questions. I'm not going to sit here and talk at y'all all day. If everybody's got good stuff out of this and we can all move on, I am down for that. CTEL staff, Lydia, everybody, are we good? Put a lid on it. Isn't that what they call it in DC? Put a lid on it.
Yeah, if there are no other questions, thank you so much for putting together and giving this presentation. Um, we're really grateful for your expertise and for all of you for joining us and being interested in knowing what to do next. If you have any questions, feel free to reach out to us or Nora. We're always available to chat or help if you have any questions. Thank you all so much, and I hope you have a great rest of your day.
Thanks for having me. Y'all take care.